Good afternoon, everyone. Thank you for joining us for this session on bridging the gap between evidence-based medicine and clinical practice. My name is Dr. Andrew Jones. I'm a clinical specialist with BMJ Group. And I'm joined today by Dr. Klara Brunnhuber, who is the product manager for best practice and clinical evidence. Now, I normally start with this quote here, and this is from Tika Pang and Muir Gray. The application of what we already know will have a bigger impact on health and disease than any drug or technology likely to be introduced in the next decade. Now, at this point, I normally say it's a very potent message, and I'm not sure how much evidence they've got for that. I've seen Muir wandering the corridors, so I'll reserve judgment for the time. One of the challenges, I think, in developing decision support products and driving their adoption is helping clinicians understand the failure of memory-based medicine. Americans receive only about half of the recommended care, and that's in a health economy where promoting the best use of the most resources is often the driver. Adherence to guidelines can be as low as 22% in hip fracture, for example. The NHS Atlas of Variation showed that there can be a ninefold difference between health systems in the UK in terms of the percentage of people with type 1 diabetes receiving all 9 key care processes. And up to 79,000 deaths estimated in the US could be prevented if all Americans were receiving consistent care. We know the adverse event rate. I hardly need to remind you at an event like this, the evidence for safety issues within UK hospitals and within the US, 190,000 deaths from adverse events in the US annually. Cost to my health system is around £650 million annually, and we know it's caused by slips, lapses, mistakes, non-uniform and poorly evidenced care, and we know it results in increased mortality, morbidity and a higher cost of care. But getting evidence into practice is very difficult. This is my favourite example. So it took 200 years before the British Royal Navy introduced lemon juice to prevent scurvy. The first study into this was in 1601, and it wasn't in routine use until the 1800s. We've got better, but not a great deal better. The mainstay of the management of acute MI, thrombolytic therapy, took around 37 years to become routinely used. International guidelines first recommended antenatal steroid use in preterm labour 22 years after the first evidence. And we estimate that on average it takes around 17 years for only 14% of clinical practice to become routine. And the burden of evidence is significant. Figures vary massively. We estimate around 35,000 biomedical journal articles. There may be 150,000 other articles, 120,000 RCTs a year. Whichever figure you believe, this volume of knowledge is far greater than we are capable of consuming. Now, no presentation at a safety conference would be complete without reference to the aviation industry, and I'd just like to ask you all a quick question. How many of you have seen a mention of the aviation industry or an airplane in a presentation this week? If you'd like to just raise your hands. How many have seen, could you keep your hands in the air if you've seen it more than twice? 3 times, 4 times? Right, we're getting there, aren't we? How many of you have been to a safety conference where an airplane or the space industry have not been mentioned? No. How many of you think the aviation industry is relevant and the learning is relevant to healthcare? Great. So I scarcely need to tell you the story. This is the Boeing 399. It was Boeing's first venture into military aircraft, and this happened. It was a very complex aircraft to fly. And so the pilot was unfamiliar, neglected to perform a critical action because he forgot or didn't know. They thought that this was a far too difficult a plane to fly, so they came up with an early decision support tool, the checklist. And the aircraft was simply too complex for any one man's memory, and the aviation industry has used checklists ever since. And the reason I mention this is not to give you another reference to the aviation industry, but I can scarcely believe how decision support in one form or another is not systematically in use in healthcare as it is in other safety industries. This was 75 years ago, and we still do not see systematic use of decision support tools to manage some of the cognitive barriers that we have when managing complex and high knowledge resourceful activities. Elson in 1997 came up with quite a nice model about looking at clinical decision making as an industrial process, and you can also see it as a cognitive model. So this dotted box is rather conceptually a clinician. A clinician has the ability to attend to things, perceive things. They've got a working memory, and they can keep very small amounts of information in their working memory, and from that working memory, they can infer certain decisions. They have a long-term memory, so there's things that they remember. There's things they remember about patients, individual patients. And there's knowledge that they've acquired through medical school and postgraduate training. And then they have external information, and this is often in the form of patient notes. These may be electronic or paper. And we have knowledge resources outside of that they can refer to as well. And we start off with a very unhappy and slightly ill patient, and we hopefully end up with a good decision for that patient. So normally, in a perfect world, the clinician perceives something in the patient. They may have examined them, taken a history, or even looked at some other piece of information about the patient. They'll pass that into their working memory, and they'll remember something about the patient, what the main diagnosis was, or something of that type. They'll look at the notes, and then they'll use their own knowledge and hopefully come up with a perfect decision. Of course, we know that doesn't happen in every situation. So we see a patient, we pass that into our working memory, we remember who the patient is and what we think their diagnosis was, and we look at their notes, and we find we have a knowledge gap, either because we've never learned this piece of knowledge or because we're finding it difficult to recall. And we know that actually at this point when people seek external sources of knowledge, whether that is in the form of resources or other people, you have a very short period of time to provide that piece of knowledge. Otherwise, the clinician tends to go and make a decision anyway, a decision which may be not a good decision and the patient gets even more ill. So the traditional remedy to this is obviously learning. We start off as junior doctors or student nurses with little knowledge. And we have to remember what we don't know, of course. And then we use external resources to increase our knowledge so that we can actually build up our long-term memory and treat patients more effectively in the future. But obviously there's an opportunity with the development of electronic patient records of bringing the knowledge in the external world with the patient data and actually provide decision support to clinicians as they're treating patients. So that when they see the patient and they remember who the patient is and they have a knowledge gap, they can actually interrogate the patient data and automatically information can come back not just about the patient but also knowledge resources which help the clinician make good decisions at the point of care in real time. And so now I'm going to hand over to Klara, who's going to talk to you about the production and development of that knowledge base.
Thank you, Andrew. So Andrew has now set the scene for us in terms of the unacceptable time lag there is between a good piece of evidence making it into clinical workflow, into the horrendous and enormous health burden it costs societies if best practice is not practiced at the point of care, and also the complexity of clinical decision-making and the information overload through all that published research coming our way. So what I would like now to do is to take you on a little walk, if you like, a scenic walk, and explore this bridge that will take us from evidence-based medicine to evidence-based clinical practice, and also relevant to now and here to evidence-informing quality and safety projects. So, when I speak about EBM, what I mean, evidence-based medicine, is the use of best available evidence, but always in the context of clinical experience, local circumstances, patient circumstances, and patient preferences and values. But what do we mean by best available evidence? And let's look at Brian Haynes' little pyramid of evidence. Starting out with original journal articles, primary research. This may be randomized controlled trials, observational studies, or even in rare disease, it may be case reports or case series. These are then synthesized in systematic reviews done very well by the Cochrane Library. They may have or may not have meta-analysis going with them. Another level up are so-called synopses. These are critiques of systematic reviews that are then published within evidence-based journals. Another level up are more summarized resources that will tell you about decision-making in the general patient. And at the very top of the pyramid, you have computerized decision support, where that evidence is put into the context of an individual patient. What is the context when the evidence is needed, when knowledge transfer occurs? This may be either a push or a pull context. So this evidence may arrive at your doorstep uninvited, or you may actually go out, like in Andrew's example, and seek out the answer to a question. Research shows that this occurs in three main areas. One is the clinical care, clinical problem. Second is learning and teaching environment. And the third, and it's on the rise actually, is when to confer information to patients and use that information for shared decision making. So let us look in depth at the EBM process. And it might start out with an information need, like we saw before, where the clinician is aware of a knowledge gap and wants to act upon it. But that may not be the case in all cases. You may have a state where the clinician is not aware of a knowledge gap and may need a bit of prompting in terms of reminders or teaching events like this in order to trigger and to bring knowledge gaps into the conscious mind. The next step will require a bit of action. Going out and doing a search. Now, clinicians like to do that by asking colleagues, and this behavior has not changed over the last 10 years, or they consult printed materials. Although, I must say, electronic knowledge resources use is on the rise. If the search is not done immediately, or colleagues are not immediately, you may need to record a question in order to trigger your memory later. And of course, because that is an extra step, some leakage may occur there too. Ideally, you will find an answer that you then assess for its validity, relevance, acceptability, and then, hopefully, implement. But we should never forget the step of evaluation. So always trying to assess the impact that your intervention, your change in behavior will have had in the context of either your quality project or clinical care. Because that may actually trigger some new clinical questions to pursue and keep this cycle going. Okay. So, 0.47, this is the average number of clinical questions that occur during a patient visit, and this ranges between 0.29, which is in a single-handed primary care practice when a student is present, up to 1.27 in a university hospital outpatient setting. So it very much depends on the circumstances. Only 30% of clinical questions are pursued, and answers are found it's a huge variety. And you see it's between 20 and 95%. And at the lower end of the spectrum are very complex questions, and also questions that are pursued by people who are not skilled at searching and appraising. Clinical librarians, when they run a search, they are mostly successful, but of course their work is then very much delayed. So it's always a trade-off of what you do in terms of the time available to answer that question, the resources that you have, your skills, and the urgency with which you will need an answer. I've looked at the enhancers and barriers for all the different steps between the different levels of the EBM process. This is based on studies identified by a systematic review by Martin Dawes on clinicians' information-seeking behavior. And I don't want to read them all out to you, but there are certain themes. And one of it, nearly occurring at each of these steps, is the lack of time. But there's also the lack of skill, depending on whether it's the skill of how to record a good clinical question, how to search, or how to appraise. Another theme is, in terms of barriers, are unhelpful resources. In terms of, let's go back. In terms of the enhancers, what seems to be key is that the question needs to be urgent. You will need to be aware of how to answer a complex clinical question. You need the relevant supervision or training. And there needs to be some sharing of best practice occurring. These are just the concepts in terms of the different barriers and enhancers. They may affect the setting in terms of, is it clinical, is it primary care, secondary care, is it a single-handed practice or a multidisciplinary team, but the patient and the problem, how urgent that is, some external input in terms of clinical librarian services, the clinician, the skill set that they may have, or their specialty, and then the characteristics of the knowledge resources. And the acronym for this that I found was SPEC, which means bacon in German. I don't know whether it's helpful, but you may find a better one. So, what do we know about the knowledge leaks for that next step, for assessing once an answer is actually found?
So what we find is once we actually have an answer to our clinical question, there are numerous leaks in that knowledge before it gets into practice, before it actually impacts a patient. And I thought I'd have a look at some of those knowledge leaks. So this red paint here is evidence pouring into our knowledge bucket at a very fast rate. And there's a few things which happen between that point and the point at which it actually affects a patient. So the first one, I think, is, am I aware of it? Am I aware of this evidence? And we lose a bit of knowledge because of lack of awareness. Do I accept it? Do I, as a clinician, accept that this piece of evidence is valid? Frequently not. Is it targeting my patient population, or is it targeting the patient I'm right in front of at the moment? Maybe not. Is it doable? Do I have the resources to do it? Do I have the capabilities to do it myself? Do I have the resources? If it recommends a cardiac MR, do I have a cardiac MR that I can access? And we lose some that way. Do I remember to do it, even if I accept it and I'm aware of it? Not always. Does the patient then agree that this is the type of care that they want to receive? And often this will be influenced as well by the physician. Physicians may very well present an idea to a patient. You don't want that dangerous warfarin, do you? Which is highly likely to result in the patient not having it. And then, of course, do I actually do it? Does it actually get done? And after all these leakages, we find ourselves with a fairly empty bucket. Now, most of us think we're probably reasonably good at all of these steps. And say, for example, we were 80% effective at all of these steps. We were aware of 80% of the evidence, and of that 80%, we accepted 80% of it, and it targeted around 80% of our patient population. It all looks pretty good. But as soon as you add all of those things up, you actually find that even if you're 80% effective at all steps, only 21% of the knowledge would actually find its way to the patient. And there's been actually some studies about what the actual magnitude of this leakage is. And it happens to be quite a lot more significant than 20% for each step. Lusenberg did a very nice study on some Dutch general practitioners, and they found that awareness accounted for 46% of leakage. 23% of the time the clinicians didn't accept the guideline recommendation. 57% of the time they didn't feel that the patient was the right target. 52% of the time, for various reasons, they felt that environmental factors affecting their ability to do it, influenced their ability to deliver against that recommendation. They found that only 40% of patients didn't agree with the treatment. So we can see that from this study, we're actually doing quite a lot worse than 80% most of the time. So I think what we'd like to talk about now is maybe some of the tools that may actually block some of those leakages. And I'd just like you just to turn to the person to your left or your right just for 2 or 3 minutes and just talk about maybe some of the tools either you use in practice, you would like to use in practice, you've seen, that would help prevent some of these leakages from the original evidence getting all the way through to the patient. So maybe I'll give you 2 or 3 minutes and we'll come back to you and see if you've got any answers. Okay, that's great. So, I wonder if anyone's got any solutions that they've used or would like to use to help make things easier to get evidence into practice. Anyone?
Very modern thing, Andrew, but there's things called apps on mobile phones.
Very good.
I have one that tells me how to implement practice.
Very good, excellent. So that's iPhone apps or Android apps. Very good. Anyone else? What about at the front line? Yes. Yeah, so taking meta-analyses and systematic reviews and using them in practice. Very good, yeah. Anyone else? Okay. All right, well, let's take a look at some of the things that might work.
So, first of all, I've collected a few themes of interventions that do work to smooth that process, the EBM process. And one of it are interventions that are very close to a specific clinical problem, clinical scenario. Those interventions that slot really well into the clinical workflow, and interventions that happen face-to-face or are interactive, like we're trying to do here, and also interventions that are combined. There's really consistent evidence that if you combine different interventions, you see a cumulative effect, much better than doing simple, single interventions in isolation. This table attempts a little ranking in terms of interventions where evidence and research exists and their impact on, positive impact on patient care. And if you see the little ratings pluses in brackets, there I wanted to indicate that there is some question around the quality of the evidence or lack of evidence. Nevertheless, clear winner are manual computerized reminders. So those things that suddenly lift a knowledge gap, an action into your conscious awareness. Other quite successful interventions are interactive sessions, as I was pointing out, workshops, small groups, one-to-one sessions, and educational outreach, academic detailing, also mentoring. So working very closely with clinicians, carried out by an expert in the field. Another one that is very successful is audit and feedback in combination. As you see further down, feedback alone has a much lower impact on patient care. I put this table together first time in 2008 together with my colleague Jane McHugh when we did a little review of reviews in this area. And when updating it for this presentation, there are two new entries, two new interventions where research has now been published or an effect has now been identified by summarizing studies in Cochrane reviews. One of them are tailored interventions addressing an identified barrier to change. So there is an impact from that, and so do go out and identify barriers of change and develop your interventions to address them. There is evidence that that works. The other entry was targeted payments in primary care, which may or may not increase the rates of immunizations. So not necessarily the way to go yet. Problems are around boring lectures and dissemination of printed materials, complete waste of time and resource. So let's be inspired by Plato. Let's look for the ideal bridge, if you like, bridging the gap between evidence-based medicine and the blessed shores of evidence-based clinical practice or quality and safety projects. So I've tried to put these factors to create that environment into these 5 different concepts around the culture, around tools and apps you may use, around the characteristics that your interventions should have, the necessary training, and potential services you may benefit from. And just to pick out a few key themes again, you need a culture where questioning is welcome, that is open for change, that is flexible, and where information sharing is valued. Information is not used as a power tool or to simply control and manipulate. And very important, an environment where time spent on answering clinical questions is seen as an important and valuable investment. We have already talked about successful interventions and characteristics that enhance and smooth the EBM process. But I just wanted to point out one point about training. Do tell users in your organization, or if you are aware of good resources, what those are. Time and time again, when we go out to organizations that utilize our resources, we find that emails, promotional events make a huge difference in terms of usage. It triples, even, it can be as high as 10 times as high afterwards. And that effect holds for a few months. So you need to do it again and again and again, because you have that high staff turnover in clinical practice. But usage translates into familiarity, and this is one of the key components, that resource characteristics that really smoothes the EBM process. So I hope that this little table may help you to focus on some of the areas where within your setting, within your organizations, there may be certain, weaker areas or certain areas that you could take as a starting point in order to come up with a strategic plan and to implement some of the resources that are out there, and to create a little roadmap for your circumstances, to create your own EBM bridge, if you like. So, let us now look at one of the successful and beneficial tools, clinical decision support tools and order entry sets.
So I thought it might be worthwhile just having a slightly deeper look and more detailed look at clinical decision support. Clinical decision support, there was a very good study in Texas by Aviation in 2009. And they looked at a range of hospitals in Texas, and they interviewed clinicians who worked in those organisations, and they did a standardised measure of the use of clinical decision support, electronic notes and records, electronic test results, etc., and correlated that to the mortality for various conditions. They found that if you were being treated in a hospital which was using clinical decision support, and you were having a coronary artery bypass graft, you were 47% less likely to die. If you had pneumonia, you were 21% less likely to die, and there were benefits if you had a myocardial infarction or heart failure. Now, admittedly, it might be argued that those are correlations, but they're fairly big numbers, those. And if we look at the cost of care, the US healthcare system wastes an estimated $700 billion to $2.2 trillion. Higher spending regions do not have better outcomes. And again, that Amersingham study showed that if you're in a hospital being treated, if you're in a hospital using decision support, your treatment would cost around $500 less on a cost base of about $21,000. Order entry systems and test results on their own do have benefits, but nothing like as significant as decision support. Osheroff came up with the 5 rights of clinical decision support. He actually stole them from the IHI 5 rights of medicine's management, but they work nevertheless. It's about giving the right information to the right person, that might be the patient or the clinician, through the right intervention format and the right channel at the right time in the workflow. A very good systematic review published by chance in the BMJ by Kawamoto. They looked at the success of clinical decision support systems, and it was a very large systematic review covering around 70 studies. They found that 75% of decision support interventions succeeded when the information was provided automatically to the clinicians in the workflow. They found that systems that were integrated as a component of charting or order entry systems are significantly more likely to succeed than standalone systems. And the remarkable thing is that they came up with 4 critical predictors of clinical decision support success. If you provide the information automatically as part of the clinical workflow, you're 100 times more likely to be successful in a clinical decision support intervention. If you provide it the time and location of decision making, you're 15 times more likely. And there's benefits to computer-based generation of support, and also providing a recommendation rather than an assessment. And I think this is a very important point. When I worked for the National Programme for IT, all we ever heard about decision support from clinicians was, I want an alert. I want an alert to tell the clinician not to do it. Well, we know what happens, and I'm going to give away some of my driving habits here, when we take to the roads and see various road signs. Now, there's some that I always pay attention to, and some I pay rather less attention to. I always pay attention to a no entry sign. Whenever there's a no entry sign, I always cannot go through it. And whenever I can't go down a road, there's virtually always a no entry sign. It's got a high positive predictive value, and it's highly sensitive. The same can be said of the right-hand turn. I once ignored this to my peril in London, and I discovered that it does have a high sensitivity and a high positive predictive value. The next one I find a little bit more difficult. Military vehicles on the road. It has a low positive predictive value. Whenever I've seen this, I've never seen a military vehicle on the road. And whenever I've seen a military vehicle on the road, I rarely see this sign. so it's got a very low sensitivity as well. So I frequently ignore this, so far to no harm. Stop signs, much like the no entry signs, they tend to be highly sensitive and a good positive predictive value. Of course, horses on the road, a bit like the tanks, often don't see the horses, often don't see the sign. Low impact, we often ignore that one. Now, the next one, you may think it has quite a high positive predictive value. When it exists, you shouldn't really do it. However, under certain circumstances, I do ignore that one. The next one, rocks falling off the hill, very similar to some of the others. Whenever I've seen this, I've never seen a rock come off the hill. I begin to have some doubts about the validity of this particular alert. The next one looks very serious, but I have no idea what it means. It's very poorly selective, and frequently ignore that one. When driving a high lorry, a high-sided lorry across a suspension bridge, I pay attention to this one, but I very rarely find myself in that situation. The next one is high impact. I don't want to be knocking children over, so I tend to pay attention to that one, regardless of its positive predictive value or its sensitivity. The same cannot be said of migrating toads, as the impact for me I consider low. Anyway, in my enthusiasm to ignore all of these perfectly useful signs, there is always a danger that you ignore one which we shouldn't have done. And when we ignore warnings, they tend to result in bad things happening. And of course, in real life, as in healthcare, or as in healthcare as in real life, as soon as one thing goes wrong, the remedy often makes the whole situation worse. And as we try and treat successive failures, generally better to avoid the problem in the first place. So one of the ways of avoiding this is we just remove all the signs that people ignore. So that in actual fact we have a fewer number of alerts, and they're all pretty good ones. But I think this really misses a point. What we really need is signs which tell us what we need to do next. We very rarely ignore the sign which tells us to go to Nottingham when we're going to Nottingham. And so we really want decision support to guide us. And of course, one of the classic tools that we hang on to in healthcare is the care pathway. But of course, care pathways are very, very difficult to implement in practice because you've got to identify the patient relevant to the care pathway. You've got to identify where they are on the care pathway. So we need to find ways of actually implementing care pathways in a better way. Now, one of the ways in which we can do this, and the BMJ have started doing this with some new software called Informatica, is actually generating clinical rules which identify patients who are relevant to clinical pathways and identifying where they are on that pathway and what needs to be done next. So we can actually code using this kind of syntax. Who is the relevant patient? Do they have a diagnosis of AF? Do they have an exclusion for warfarin? Have they had warfarin, and are they at high risk of stroke? And we can put that into a clinical rule, and we can actually, this is a visual representation of that clinical rule, and we can use that rule in a number of ways. So we can use it to generate alerts, but alerts which tell you what you need to do next. So we can see this patient has chronic AF, and the system has calculated that they have a high risk of stroke from their CHADS-2 score. So in actual fact, we can indicate to the clinician that this patient may be considered for warfarin. And we're actually telling them where the patient is on the pathway, that they're relevant to this pathway, and what the clinician should do next. You can also use this rule, this clinical rule, away from the patient, so not at the point of care as such, and generate a proactive approach to identifying all the patients who are at that point in the pathway and might be considered for that treatment. So we're enhancing our ability to target the right patient population, and we're improving the recall of the clinician that this might need to be done. So we're helping them do the right thing. We're not saying the patient has to have the treatment, but we are saying that the patient should be offered it. And then, of course, we can actually link evidence-based medicine tools into the clinical record. So here you can see a list of links to evidence-based medicine resources based on the patient's problem list. So we can actually target the information relevant to that patient in that patient context. And the clinician can go away and convince themselves that this piece of evidence is something they agree with. It certainly can raise their awareness and help them with implementing and doing it by giving them other information. If they need any convincing that this is a particularly valuable piece of evidence, then they can look at the original research or guideline. And they can also find other resources which actually tell them how to prescribe these, this treatment in this case. So we're helping the clinician understand what they need to do. We're helping them identify and target the patient. And we can also help them educate the patient or help the patient come to their own decision, an objective decision about whether this is a treatment that would be right for them. So within the patient context, again, we can provide them with patient information resources. We know that patients remember about 2.4 things that I say, well, probably less in my case, but on average 2.4 pieces of clinical information that they're told during a consultation. So being able to provide them with patient information at the point of care is very important for their ability to make an informed decision. And then we come to actually doing stuff, actually delivering. Once we've accepted it, once we have, once we know it's doable, once we know the patient wants it, how do we ensure that these things are done? And there's a few tools which can help us with that. This is a care bundle used extensively in the UK now, increasingly so. This one's a very simple one. They often only have 5 or 6 interventions. They're often focused on a specific clinical intervention. And when they were introduced in a northwest London hospital, they found that by implementing just 8 care bundles, which targeted around 13 diagnoses, over the year they saw admissions increase by nearly 6%, which is about normal in the NHS. And they would have expected to see deaths rise by 8%. And they saw a 14.5% decrease in actual deaths, and that represented 255 fewer deaths. And you might be saying, well, how do you know that was the care bundles? Well, we don't. But what we can say is that only these 13 diagnoses saw the benefits in mortality, and this particular trust had 2 sites, one of which implemented the care bundles and one of which didn't. Only the one that did saw an improvement in mortality. And in actual fact, if you scale that up over the whole of the NHS, that would represent 36,000 fewer deaths in a year. Another tool that we often think about using is our clinical guidelines. And they're very, very thorough and useful documents. However, at the point of care, I very rarely use them, and this is the reason why. This one has 173 pages, it has 67 recommendations, and it's based on 380 references. And in fact, it was published in June 2006. The prospect of me opening this with a patient next to me is bordering on 0. But there are things that we can do in order to make these guidelines far more effective and far more useful and far more actionable. And if we take those actionable pieces of information out of the guidelines, of which they're described in various levels of clarity. So sometimes you'll have a standard beta blocker, other times you'll actually have drug names referenced but no drug doses, etc. So we can take all of these actionable pieces of information, all these pieces of information that you actually can use whilst managing patients at the point of care, and we can turn that into a list of orders or care protocol which can help us remember all of those elements of care which are evidence-based that you may wish to offer your patient. And of course there's things which aren't in the guidelines, and we use other resources, including our ability to systematically review, to actually fill in all those gaps. And that leaves us with an overall order set or care protocol. And these have been shown to be incredibly effective at delivering evidence-based care. A systematic review which looked at studies into order sets over 10 years, they found 16 studies which examined the effect of order sets on outcomes, and they found that 88% of them demonstrated improved outcomes or adherence to guidelines. 4 showed a reduction in mortality, and 4 showed a reduction in length of stay or cost. And these are big areas like VTE, acute MI, and diabetic management. And of course, you can integrate these order sets into clinical systems, and this is where they become most effective, and we get them into the workflow most effectively. Now, this is the Cerner system, and this gentleman has been admitted into the emergency room with chest pain, and if we open up his record, we can see that we've recorded his diagnosis of acute chest pain. Now, if we click on that, we are automatically provided with the order set which actually is relevant to that condition. And here we've got one which is the management of acute chest pain and one which is the management of pain in an adult. And if we click on that, the system, the order entry system, automatically gets populated. You can see the order set is phased depending on where the patient is and on their journey, but you can now see it's automatically populated with those evidence-based recommendations. So a junior clinician doesn't have to think about they don't have to remember every element of care. And a lot of people say this is cookbook medicine, this is, this is going to de-skill people. And I use the analogy of a sat-nav system. When I moved house recently, I needed to use the sat-nav to get to the local supermarket. And I don't need the sat-nav to get to the local supermarket anymore. I just happened, by using it for that period of time where my knowledge was poor, it made sure I got there every time. I didn't have to learn by my mistakes. And in actual fact, I don't use the sat-nav anymore, and I've improved upon it. But this allows junior doctors particularly to learn and treat more effectively around certain condition areas, including drug doses, which will reduce medication errors, pathology tests, and even specialist referrals onwards. And one of the really exciting things about this is that you can also move through the patient journey, and then as the patient moves through their journey, for example, in this case, they're diagnosed with an ST elevation MI, we have a whole new set of evidence-based orders, and that allows us to move forward with the patient's treatment under a different set of circumstances. So we're following the patient all the way through. You can also have drug links in there, so you can actually help them provide care more effectively. And the nice thing about these opportunities are that we can also now show the clinician at the point of care what the evidence is for the particular element of the order entry set. So we can give them we can give them an evidence summary, so it can tell you why an ECG is relevant in this situation or any other element of care. And they can go in and find more detail, in fact, about how they might want to manage the patient according to the evidence. They might want to have a look at the common differential diagnoses, how those differential diagnoses compare, and what the evidence is in order to support the diagnosis of these conditions. And of course, when we're with patients, it's one of the main times where we identify our learning needs. When we have a knowledge gap, and we notice that knowledge gap because we're managing a patient, we need to be able to facilitate people to be able to record that quickly and easily. So they can actually say, well, look, I've managed the patient effectively using this order set. I've looked at the evidence. I haven't got time now to review it in any greater detail, but I can actually record that this is a learning need of mine. And we're following the clinician's knowledge journey throughout the point of care and onwards into their learning environment, so that when they are in their learning environment on a Saturday afternoon on the sofa looking for some CPD to do, they can actually go back and remember those things that they had identified as learning needs while they were in front of the patient. And we know that if we don't facilitate this, 90% of the time we forget what we needed to learn. And of course then you can go off and do some learning based on that, and learning modules, etc., and keep a record of those. So that's really some ideas about some of the tools that we can use to get evidence more effectively into practice. We know there's a knowledge gap, and we need to provide actionable knowledge at the point of care, which can be really effectively implemented by clinicians. We need to provide referential knowledge resources to help them communicate with the patient and develop their own knowledge, and improve outcomes in that way, but also help them identify and record their learning needs, provide them with learning resources where relevant, and record that learning activity to close that knowledge gap. So I thought I'd finish with this. I'm not going to murder the French language, as I have been with taxi drivers and waiters for the last 3 days. But this is a quote from Louis Pasteur. There's no such thing as a special category of science called applied science. There is science and its applications, which are related to one another as fruit is related to the tree that has borne it. So I'll leave you with that thought, and thank you very much. Happy to take any questions if there are any. Do you want to answer this
One, I think. Is it working? Yes.
Yeah.
Thank you very much for a very nice presentation. I keep thinking about the people interacting with your nice record system. How many people are actually working on supplying new information about the newest evidence? And do you know anything about how doctors interact with the system in clinical practice?
So the question was that how many people are actually updating the evidence?
I think there must be a load of people behind such a system.
Yeah.
And I would like to know.
I mean, the volume of evidence has actually become such that within our own organisation, we've had to look at the way we process and develop our evidence synthesis. And we've developed an evidence engine, because with 35,000 journal articles coming out on an annual basis and increasing volumes of evidence coming out of emerging markets as well, I think the key thing is, in order to make that process efficient, is identify where change has occurred. Traditionally, we would go through every single piece of content that we had on a monthly or a daily or an annual basis, depending on the relevance of the content. And actually, what we've moved to is a system where we're identifying the change. So we're scanning constantly for changes to the evidence and then updating all our content. But it's something that organisations often try to do on their own. And when you come down to the actual magnitude of the problem, it's not something that most normal-sized organisations are capable of doing.
I don't know whether your question related to our own, the Evidence Centre where we work, but we have around 70 people of staff, and a third of them are involved in identifying relevant research and then summarising, handing over to clinicians in order to put into context of the current content base, and then also in order to push that into our content management system and then publish that. Another two-thirds of the department are around the background of production, health informatics. It has become quite a large team now. The action sets team that will then implement it as order entry sets, and people that will then, like Andrew would, clinician specialists, in order to identify what would be the needs of users. So I don't know whether that answers your question a bit. Okay.
I have a comment about the statement or the belief that audit and feedback is a useful tool. There is increasing evidence that the way we use audit as clinicians has actually failed to actually improve our adherence to standards of care or even to evidence-based medicine. The Cochrane Review of Audit Practice in 2010 showed that on average it increases adherence to standards of care no more than 5%. And in fact, in some studies, a reduction in adherence to minus 16%. And I see this every day in clinical practice, where our trainees, our medical trainees, are tortured by audit, I mean, a trainee 4 years in will have done about 16 audits. And I sat in an audit meeting on asthma, and I was faced with a recommendation slide that said, we recommend the following regarding adherence to the asthma guidelines, which are well understood. And a colleague stood up and said, well, in 2005, I made exactly the same recommendations. In other words, we are failing to adhere to these evidence-based standards, and I think audit, the way we use it, has failed.
Yeah, I mean, do you have any solutions to that problem?
Yes, I think that, well, I do, and I think that, in England, we're now beginning to say we have to get beyond audit and actually start using the tools of quality improvement.
Okay.
And actually, I think that's fundamentally the approach we're now beginning to take, which is, if we think that the asthma guidelines are useful and the knowledge needs to be used, we need to start measuring what we're doing to our patients, and then understanding, constantly measuring our system, and then going back and saying, what is our system failing to do in terms of the outcomes that we want? And not just do it and as well as audit does, snapshot 1 year. We have a national audit on asthma, which is a measure of process that keeps telling us the same thing. We're failing to adhere to evidence-based medicine. So I think the solution is quality improvement methodology, not audit.
I can't disagree with that. Yeah. I mean, I think, when we talk about audit, and I think those features of it being a single episode of measurement, I think for me that's never been what audit has meant. It has been exactly what you've described, which is a constant process of measurement and measuring outcomes rather than process. I think are other things that are going to make a difference. Yes.
Very interesting presentation, and I think it's intuitive to most people that the successful application of computer-based decision support technology will prove to have merit, and you presented data that supports that. There are two challenges to this, though. First challenge is that for many conditions and many interventions, there's insufficient reliable evidence that something actually works, so that the evidence base is not what we'd like it to be, and in fact, for some conditions, the evidence base may never exist because the studies may never be done. So if you could address that, I'd appreciate it. The second comment is that you made a point about the standardized lists for investigations and interventions that helps the junior doctor. Well, I would counter that it stops the junior doctor from thinking. I gave my daughter a GPS device for her car a couple of years ago, and I said to her, look, Megan, if this ever breaks down and doesn't work, there's a map in the pocket. And she said, well, how do I use a map? And how do I identify where I am on the map? And I said, well, this is a bright young woman who goes to a world-class university, but she's grown up in an era where the technology feeds her information, and if you take the technology away, she's sort of struggling for where the information resides. So what do we do with the evidence that doesn't exist, and how do we overcome the inherent dangers of overutilization of technology that may interfere with learning?
If I could address your second question first, I think it very much depends on the context in which you're using decision support tools. I think in this context, we're using tools with highly motivated, intelligent professionals doing a job where they have an incentive, an innate incentive to learn. I mean, my experience with satellite navigation, GPS, is that I do learn whilst using it. And if you look at aviation, this might be the last time you hear about aviation in this conference. If you look at aviation, when they developed automatic landing systems, what they found was that the pilots, having thought that they'd be able to put their feet up and have a cup of coffee and push the button and watch it land in Singapore, was actually not the case. And the training shifted from actually the mechanics of landing a complex machine to actually managing the automatic landing system, the decision support tool, and how to have knowledge about how to override it, when to use it, when not to use it, when was in this case the relevant patient, and when should you actually use your own initiative. And I think if we can take these very cognitively intensive, memory-based tasks off the hands of clinicians, then clinicians can focus on what they do best, which is complex problem solving and talking to patients. And those two things will never really be solved by clinical decision support. And I think if we can take these memory-based tasks off the limited resources that we have, then we can actually focus on the bits that we do well. Klara, I don't know, you want to answer the first piece?
Shall I answer your first question? I think it's important to stress that evidence-based medicine, if it is done well and collecting best available evidence, very much means to identify those interventions where there is not sufficient evidence. And what we find in clinical evidence, for example, where we have collections of systematic reviews, that over 50% of all interventions that we look at systematically come out as unknown effectiveness. And this has a sort of a series of facets to it. There may be no research, and there's a real research need. There may be some research, but it's of such rubbish quality you would not want to base any recommendations on. And there may be also situations where there will never be research because it's not ethical to do it, but you still need to act. And I think it's very, very important to make that clear so that it becomes obvious to clinicians what they are basing their recommendations on, whether that's weak or strong recommendations going forward. And I think that's what the GRADE working group tried to do, by not just looking at the quality of the evidence, but also how strong in the strength of the recommendations, to take it to that level. And also, I think, where there is a gap in the evidence space, and this is very much an area where you may need to start talking to your patients. So there's a space here for patient decision aids and for shared decision-making, to find out what are the patient's preferences and values in this case where there is not enough evidence to really make a clear recommendation to the patient.
Okay, I'm conscious it's 2 o'clock. All our contact details are there. Please do feel free to get in touch or come down and have a chat with us. Thanks again.